Welcome to our webinar, SAIL for First Nations, Fall and Injury Prevention Project. In honor of November as Fall Prevention Month, Osteoporosis Canada and the Fall Prevention Community of Practice are teaming up on a series of 4 webinars. This is the first. My name is Lindsay Toth, and I am a project coordinator at the Ontario Neurotrauma Foundation, the sponsor of the Fall Prevention COP. I will be facilitating the webinar today, and my colleagues Marguerite Thomas and Hélène Gagné will be in the background assisting with the webinar technology. Before we begin, I'm going to give you a quick rundown on the Level 3 web meeting system. This webinar technology consists of 2 parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. The phone number for the conference line and the link for the web platform were sent to you by email after you registered with for the webinar with Level 3. If you have questions about the technology at any time during this presentation, please type them into the chat box located on the left-hand side of your screen. Alternatively, you can send me an email to lindsay@onf.org, and I will work with you to resolve technical issues as soon as possible. This webinar will contain an opportunity for discussion during a question and answer period at the end. If you have topic-related questions during the presentation, please type them into the chat box. During the Q&A, I will read those questions aloud to the presenter. If you would prefer to ask your question over the phone, we'll give you those instructions later on. This webinar is being recorded. The recording and the PDF slide deck will be distributed by email after the webinar. Please note that all the images in this presentation are not to be copied or reproduced for any purpose. Many of these photos are provided by elders with specific instructions only to be used for the SAIL project. I would now like to introduce our speaker, Dr. Vicky Scott. Dr. Scott is the project lead on the Strategies and Actions for Independent Living, or SAIL, program, which is being adapted for First Nations communities in British Columbia, Canada. She is a clinical professor with the School of Population and Public Health at UBC and a core research member of the Center for Hip Health and Mobility. Vicky, we welcome you, and you may unmute your line now by dialing *7.
Thank you, Lindsay, for the introduction.
No problem. Take it away.
Thank you. And hello, everyone, and thank you very much for joining this call and for your interest in this topic. I'll be advancing the slides and look forward to your questions along the way, and I will leave time at the end for more questions. So the SAIL for First Nations project is funded by the Ministry of Health in British Columbia through the Center for Hip Health and Mobility. The project operates over 3 years, and we are operating in partnership with the First Nations Health Authority. And my acknowledgement is to thank the home support staff, elders and families, and the others in the First Nations communities who shared their time, experience, and wisdom to help adapt the SAIL program in British Columbia. And in particular, the elders. They were very forthcoming and willing to have us talk with them and to visit their homes, which was incredibly helpful. The agenda includes talking about the background of falls for First Nations communities, the SAIL First Nations products, how we evaluated the products, and then I'll talk a little bit about the next steps. So our project goal was to adapt the SAIL program for cultural relevance and for local application in First Nations communities. So for those of you who do not know about the SAIL program, it is now available across the country, and I'll give you that website later on. It was developed in British Columbia for the British Columbia Health Authorities as a program for home support clients who receive publicly funded home support services. And each health authority in British Columbia is now operating the program and monitoring and evaluating it. And that's been going on for at least 5 years to some degree in each of the regions and now spread more widely. However, 2 particular First Nations communities reached out to us and said, great program, but it doesn't work for us. We are in isolated communities. Our populations are different. The images don't represent our people, and we deliver health services in a slightly different way.
Sorry to interrupt, but I'm having difficulty in hearing you. Cutting in and out.
Oh, really? Okay. I'll speak more loudly. Lindsay, if this continues, I can switch to my mobile phone. So anybody else that has problems, let me know.
Yeah, please do let us know if you have difficulties with the audio by letting us know through the chat box. And you can also hang up and call back in. It's a low-tech solution, but it does tend to fix most issues. Sometimes you just call in and it's just a bad connection, a bad line, so that will help fix it. And you have a volume control on your individual phone as well that you can use to adjust the volume.
Thank you. Okay, I'll make sure I speak quite loudly, but let me know if the volume is too high as well. So as I was saying, the SAIL program operating throughout British Columbia through the health authorities, and then we were approached by the First Nations communities to say they would like to adapt it. So we managed to receive funding, and our approach was to adapt it with them. So on the slide you're looking at now, this is a typical First Nations community in British Columbia. It's called a Howsit, and it's on the west coast of Vancouver Island, and the only way to get there is by water taxi or float plane, and the water taxi takes about an hour depending on the weather and can be very rough. So you can imagine if you're an elder, you have a health problem, that's your only way of getting out of this community. It's your only way to get out to go and do shopping sometimes and to go to a doctor's appointment in many cases. And if you have a medical emergency, this is how you get out, by the boats, by a float plane. And in the middle of winter, that can be quite an ordeal. So this next slide shows you the steps that we took with our project. So our first step was to develop an advisory committee, and this is primarily people from the First Nations community, and in particular the First Nations Health Authority. So here in British Columbia, about 2 years ago, the First Nations communities developed their own health authority. We have 5 for different regions within the province, and now they are the 6th health authority for their own communities. We're primarily talking about communities with on-reserve populations. The first step after the advisory committee was to offer training workshops. So this was taking the original SAIL training program and offering it in First Nations communities, and I'll show you a map in a minute where this happened, but each setting had many band representatives from the whole area. So we actually covered quite a bit of the province. And at the training workshops, we welcomed input as we did the workshops on how to adapt it. So we did 8 workshops, and every time we did it, we adapted it to be more culturally and relevant and appropriate for First Nations on-reserve communities. Then after 6 to 8 months later, we would go back and choose 1 or 2 sites, 1 or 2 band sites in each of the regions, and did an evaluation visit. We went and interviewed the elders, interviewed the staff, interviewed the management and others involved in the program, and asked them how it was going, what were the successes, what were the challenges, and how could we make it work better for their settings. And then we would adapt the program and go back and improve the training, improve the material. So it's an iterative approach where the materials were constantly being adapted as we went along. Our final event was a summit meeting, and this occurred just 2 weeks ago in Vancouver, where representatives from all those bands came, from each of the sites, I should say, came to a meeting and had a look at the final materials, gave presentations of what they were doing, their successes and challenges, so they could share that with each other, and then we're making the last improvements, and in early next year the final products will be ready, and I'll talk about what we're doing with those in just a minute. So this slide shows you where the workshops occurred, and so there were 8 of them, and our province is very empty up at the very top, but very populated at the bottom. So we had some very remote and rural communities, particularly the one in Haida Gwaii, formerly called Queen Charlotte Islands, now called Haida Gwaii, off the west coast here. the New Chalmeth bands, two settings very, very remote. But then there's the Cowichan band, which is actually the largest group of on-reserve First Nations people in British Columbia, and then the coastal band, so quite urban in many cases. So quite a variety of settings for those. The next slide about the scope of the problem, and it shows that falls are the leading cause of injury and hospitalizations for seniors, including motor vehicle crashes, and this is in First Nations communities. And fall injury rates in the First Nations population are twice those of the non-Aboriginal population, and this includes hip fractures due to falls. And prior to this webinar, you were given some recommended reading, and one of them was an article, and this is a table from that article on unintentional injuries in British Columbia among First Nations. And as you can see with the two red circles here, the total BC population rate is 33.6, and this is a crude population rate of 10,000 person years. But for the Aboriginal on-reserve population in British Columbia, the rate is 60.4. So that's what I'm talking about. It's twice as high. So another source of findings that influence what we're doing, we have tested the SAIL program, and in one study, a controlled study, we showed that there were 82% of the falls occurred inside the client's home. So remember, we're talking about home support clients, and in order to be a home support client, you're going to be frail. This is publicly funded home support. So it's not surprising that these clients would be spending a lot of time in their homes. However, 37% occurred in the morning, and that really leads us to looking at fall risk that occurs getting out of bed, going to the bathroom, people who are unsteady on their feet when they first get up in the morning. You know, it leads you, with this kind of data, you can better target your interventions. Most falls were unobserved. A number of these clients live alone, and even if others lived in the home, they were still unobserved. And of course, very few actually happened when the home support worker was in the home. Only not even 5%. So we wanted to capture information about all falls, and I'll tell you how we do that in a minute. What we also found out is when the home care assistants and the health professionals were trained with the SAIL program, they were able to reduce their client falls by 44% over 6 months, and that is published if you want to look that up. So the philosophy of the SAIL for First Nations, as we're calling it, is that the most important part of fall, and we also include fire prevention, and I'll talk about that in a minute, is respect for our elders through a shared learning of their risk and supporting their choices for risk reduction. And this was key, and the program, I think, has been successful and has worked well because we pay attention to listening to the elders, to listening to the people who work with them, listening to their families, and listening to the issues that affect their communities in the bigger picture. And there's some reading list that has been sent to you that really talks about articles that talk about the importance of being a good listener and using a collaborative and cooperative approach to developing a fall prevention program. This is another piece of background reading. This was a symposium that was held in Victoria, and it was held at the University of Victoria, and it was done in partnership with the Native American population. We had representatives from the Centers for Disease Control and the Indian Health Service in the United States, as well as across Canada. And it was the first ever symposium or any event on fall prevention for the Aboriginal community in Canada. So we were very excited that it was so well attended and represented. And this is a document where we talk about what we heard. We invited the elders and the people who work with them to come and tell us their stories. And this document gives you that overview of that project, that program. This next slide came out of that symposium. Dr. Charlotte Redding has put this model together that represents for her the determinants of health for Aboriginal elders in Canada. And I've added fall and injury prevention because it fits very well with all the other health issues. And the point being is that the health issues in our Aboriginal community come out of distal determinants and intermediate determinants. They're influenced and by the residential school systems, by the Indian Act, by colonialism and policies. And that translates into economic insecurity, racism, inadequate housing, and poverty. And these issues haven't gone away. These are still there. You hear them on the news all the time. But all of that influences the health conditions. They don't operate in isolation of that. And this includes the risk for falls and injuries. So we're very much aware of this when we go into the communities and talk to the elders and realize that challenges are big to overcome to help promote health, and they need to be understood and supported in that process. But there are also many strengths that we learned through this project when we went into the communities. We learned that there's tremendous respect for the elders by everyone in the communities of all ages. The close family ties, often intergenerational living conditions where there's the elders providing care for the grandchildren when their children go to work, and tremendous bond of close family ties. People will come back to the community to care for their elders when they when they are in poor health or need support. There's strong beliefs for spiritual beliefs that really sustain a number of the elders through severe health problems. Community belief, there's an obligation to provide support to their elders. There's a low turnover among the home care assistants. Many of them live in the community and are related to the elders that they're providing care for. So there's a bond, there's a familiarity. And the home care assistants typically live within the community, and they know their elders. So these are all strengths that really make health promotion and support work. And also, the SAIL program from the start was designed to be consistent with the Accreditation Canada required operating practices for falls. And so we very much work on a team approach. We have tools for identifying risk. The strategies are specifically designed for the populations at risk, and in this case, we're tailoring them for that First Nations population. The team is taught how to do evaluation and how to use that evaluation information to improve their fall prevention strategies. So many of them do have to go through accreditation, and with SAIL, they are doing well. Now I'm going to move on to the SAIL products. Lindsay, are there any questions so far that I need to stop and answer?
Nope, it seems like everyone is just listening and content with that for now.
Okay, and anyone having problems hearing me? I'm pretty well speaking at the top volume I can. But
I've heard from a few people that it's much better, and that it seems like the majority of people are hearing you just fine.
Lovely, thank you. So the SAIL products are broken down into two parts, what we call our core products. And these are the ones that we say to the communities, if you want to say you're doing SAIL for accreditation purposes, for example, you would need to be using these products. There are more products, and many of the what we call our enhancement products are products that the First Nations community asked us to develop, so they did not exist in the original SAIL program. They are new and just for this particular SAIL First Nations package. So I'm going to go through each of these, and the first one being the training, which is the core of the SAIL program, that people be trained with the slides that we have developed. And I should say that this program, this SAIL for First Nations program, was developed just for British Columbia, and most of the products are for the First Nations people through their website and just for their staff. However, there are many products that are available, and I will point those out to you, ones that you can access right now and anybody can access. And finally, at the end, I'll talk about how we're planning to readapt the project to be available for across Canada, but that won't happen till next year. So what I'm focusing on today is mostly how to develop a project for Aboriginal communities across Canada, how you could do it, how we've done it, and how you could take this information and do it yourself. And we will share some products, and eventually all of them could be available. So when we talk about staff training, there are two stages. And the first we recommend is that the leader, the community leader who will be running the SAIL program, we recommend they take the Canadian Fall Prevention Curriculum. Now, this is a course that's available online and in most provinces in Canada, also available in each province. And if you go to the website, thecanadianfallprevention.ca, you will see how you can find out where the workshops in each province are being held. And if you go to and that will lead you to the e-learning version, but also through the University of Victoria. It's a certificate course, and it teaches you how to design, implement, and evaluate a fall prevention program. But it's based on the latest evidence on what works to prevent falls, how to implement programs, and how to evaluate them. So the leader is the only one that would need to take this course. And then there's the SAIL for First Nations training. And that is offered by the leader, who's now familiar with the topic through the CFBC. And it is operated on over 1.5 days. And what we learned, one of the biggest things we learned from giving the training is that we wanted to have them demonstrate their learning. And we were, in the very beginning, doing 2 full days of staff training, and over time that got changed to just 1 day of training. And then on the second day, which is only now a half day, the elders come, and the participants from the first day practice their fall prevention learning with the elders. And I'll talk a little bit how they do that later on. The next key product is the calendar. This is very important. It goes into the home of the elder who's on this home support program. And this is not the final version you're looking at. It's going to be adapted so that each community can make it their own. In other words, they will be able to put all their community events that are important for elders onto their calendars. So it won't just be a fall reporting calendar. It will be a community event calendar, and they can even tailor it for the individual by putting family member birthdays and things like that on it. So that was one of the main recommendations that came from the community. So this will be just a template that will go to each community to adapt and brand and put their own logos, and it will look like their community calendars. But from a fall prevention point of view, the instructions are that a check mark go on every day that there's no falls, and an X on every day that there is a fall. And then when there's a fall, they are to fill out this fall report. And you're just seeing part of the fall report. But the idea is that it collects information on where, when, and why the fall occurred, and any injuries that resulted, and actions that were taken. The communities are also provided with a database, an Excel file that generates summary reports automatically. But many of the communities have their own databases, and they're integrating this now into their own databases, which is even better, and that will generate reports as well. So every fall gets entered, and this is falls whether they're witnessed or not, and if there's no injury or an injury, in both cases, they fill out this fall report. And the database allows them to track the falls for an individual to find out if they're a frequent faller and look at patterns and locations and time of why that person's falling. That information is used for a fall prevention plan for that individual. And then it can also be tracked across the community. So they can tell, are people falling, getting into boats, leaving the community for their doctor's appointment, for instance? How often is this happening? You know, what time of year, what time of day? So it gives them community-wide information to help with prevention planning. The next core product is our checklist. And here, this is where we focus not only on falls but fire prevention. This actually came from work that I did earlier with the Navajo Nation down in the United States. And in that project, I was partnered with the Indian Health Services down there. It was found that it's seldom that health promotion gets into the homes of elders. And when that happens, it's best to use your time wisely to do more than one thing. And the risk for falls and fires often overlap. An example would be somebody who has dementia or other cognitive limitations who might leave the stove on, might put flammable materials too close to their wood stove, things like that. Things that can cause trip hazards could be also fire hazards. You can't get out of your home if there's a fire, if there's clutter or hoarding occurring. That is a risk for a fire-related injury. It's also a risk for fall-related injury. So we found that overlap good. So this is our way of doing both in home inspections and awareness raising for both fall and fire prevention through this tool. And this tool asks if they have a problem, and if they don't, that's great. But if they do, it provides suggested changes that could be made, and it also has a tracking tool to monitor change and other information on fall prevention. And finally, the other core resource is just an awareness-raising tool. So this is just a handout. It's also used as a poster in the health centers in the First Nations communities to let people know the key points about falls and fires and tips that they can share among themselves on how to reduce falls and fires. So it's just an awareness-raising tool. Now we're getting into the enhancement products, and as I say, many of these came at a request from the communities. And some were adapted from existing resources, and others were brand new. So this first one was adapted. There was a tool that when I was working at the Ministry of Health that we developed called the Staying Independent tool, and we've adapted this, and it's a fall risk screen that now has the images of local First Nations people and reflects the way they provide their home support and who they would talk to about their fall risk. So one side is information, the other side is a checklist that scores their risk and why they're at risk for falling. So it's a tool that they fill out with their health provider, but many of the First Nations communities are now handing this out at any gathering where elders gather, elders' lunches, elders' events, and they get them to fill it out, and they can identify who's at high risk, even if they're not on home support, because they want to help, of course, all the elders who may be at risk of falling. And if they score highly, we recommend that they use more tools to assess why that person's at risk. In other words, dig a little deeper. And to do that, we recommend these 3 mobility assessments: the timed up and go, the stand test, and the tandem stand test. And these are maybe slightly different versions that you've seen elsewhere. And I'm going to go through each of these because they are validated tests. They're easy to use. You can train non-health professionals on how to do them. This is something, as I mentioned in our workshop, where we have the staff trained on day 1, the elders come on day 2. They practice these tools with the elders. They're demonstrated the first day, they practice them with each other, and then they do them on the next day with the elders. So the first is the tandem stance test. And it's more than just the basic tandem stance. It's a 4-stage tandem stance. This is a tool. This is recommended by the Centers for Disease Control in Atlanta, a colleague I work with down there. They find this gives much more information than just the basic tandem stance step. So you start off with 2 feet without holding on, then slightly apart, then 1 foot in front of the other, and then you only move on to each stage if you can do the first one ahead of it. And the 4th stage, if they can stand on 1 foot for 10 seconds, then that's the highest stage. And I'll tell you, when I get to our next enhancement project, I'll tell you how we use this with the elders and what the findings were. The second test is the 30-second chair stand. So they sit down and stand up over 30 seconds, and it's how many stands they can do in that time with their arms crossed over their chest. The safety feature here is to have the chair against the wall so it doesn't move. I should say the safety feature on the tandem stance was to make sure they had something to hold on to as well. The next test, and many of you may know the timed up and go. So it's a 3-meter walk, and it's timed, and any gait problems are observed. And so the reason the 3 tests are done is the first one measures balance, the second one measures leg strength, and this one really pays attention to gait. It also would tell you about strength and balance, but this one gives you a chance to look at how they walk, any gait problems. Another enhancement project, and this one, I must say, has been one of the most popular products. And this is one that's freely available right now to anybody, and it's a home activity program for frail elderly people. And it was not. It was one of the products that was not adapted specifically for the First Nations communities. They said it was fine the way it was, and also it's based on videos that were quite expensive to make, and they didn't feel the need that we needed to reproduce them. So there's no First Nations people in these videos, but they're fine with them the way they are. So the home activity program, and there's the website. It's all on YouTube. There are 3 levels. Each level has 7 exercises, and each YouTube video at that website has a separate video for each exercise. So you can tailor a program for an elder or a senior, wherever you're working, just saying these 3 exercises at level 1 would be good for you to do. And we recommend people just start off very slowly. So you don't have to do all 7 to start with, and each video can be shown separately. And there's handouts that give a picture of each exercise at that website as well. And this home activity program is now widely used across British Columbia. You'll find it posted in hospitals and doctors' offices, and it's not specific to home support clients, but it's certainly a safe, because it's all either at the kitchen sink or they're holding on to something, and there's a sitting version, and you can, as I say, tailor it to the individual. So do have a look at that. But in the First Nations communities, they were saying they very much wanted to have a group exercise option. And once again, through work that I've done with the Native American populations, I've learned that Tai Chi was very well received as a group exercise in many of the Native American populations. And so we asked if this would be something they would like to try here. And so with the Cowichan Band, we did a pilot project using the Tai Chi as a group exercise before the elders' lunch. So on the reserve setting, the elders that were on home support or who were frail were brought in a public transportation mode, in a bus that was provided by the band, to the center if they could not get there on their own. And we asked them if they would like to be part of the project, and we had 12 people who said yes. And we used those 3 balance tests, plus one other life-space questionnaire, as a pre-post-test method before and after 14 weeks of Tai Chi with 3 lessons per week. And that was the recommended amount based on the literature. And there are at least 2, maybe now 3, randomized controlled trials with elderly people to show that Tai Chi does reduce falls. Fuzon Lee is the publication, F-Lee, L-E-E, if you want to look those up. And so we found with those pre and post tests that there was significant improvement in all. They all improved their mobility, their strength, and their balance over the course of that program. We also had a qualitative component where we interviewed them about the benefits that they felt they got from the Tai Chi program, and from that we produced a video. And the website that you have there is the video interviewing the elders about the benefits of Tai Chi. And I do recommend that you watch it. It's a very moving video where the elders really speak from their heart about the importance that Tai Chi became to them, much more than just a physical activity, almost a spiritual experience and relaxation. And anyway, I won't say any more. I just recommend that you watch it. It's a very moving video. So that now we have a whole package that will be available here for our elders that has instructions and handouts and photographs of each move, so they can have their own Tai Chi programs in their communities. And then we have a fun product that was actually developed by a group of bands in one of the regions that they've shared with us, and this has been a very popular item. So with the workshop again, staff on the first day, the elders and the staff on the second day, they play fall prevention bingo. And they just learn so much about falls and have a great time, and there are prizes, and it's been incredibly successful for awareness raising and has taken off in many of the communities and used not just in the training sessions, but just used for fun. And it brings awareness of fall prevention to the whole community in a fun way. So those are the enhancement products. We finished with the core products, and now this is where we're at. We're working, and our summit that I mentioned earlier was so key on helping us with this part of our program, and this is the implementation part. And as all of you in fall prevention know, it's always a challenge to actually make something sustainable and fun and meaningful and that makes a difference. And so we have really worked hard to help to ask these communities, ask the elders, our advisors, their family, the staff, everyone, how this could be better implemented. And what we learned was that we need to have the program reflect their spirituality, their culture, that it be integrated into their community. The band leaders need to be involved. All the staff, family members need to be involved to really make it meaningful. And it must center on the elder and their wishes, their beliefs, and their strengths and support for what they want. And then, of course, the circles around are what we've learned that we need to make it happen. We need good leadership, somebody who is well-versed in fall prevention, somebody who's able to put a program together, and we have found excellent leaders in these communities, very impressive, and how competent and capable the leadership is in these communities and how tapping into that has been so worthwhile. And then, of course, you need administrative support. You need someone to enter those fall reports. You need somebody to do the printing. You've got to have that infrastructure. And in some communities, they're very small communities, and they have very few resources. And this is a lot of them don't have internet access. Some of them don't have even telephone access at some times. They're really, really remote. There's no, for instance, in many of the communities, there's no emergency number that you can call, no 911. There's no ambulance service. There's, the infrastructure is really daunting. VHF radios is sometimes the only communication, very old technology. So it's quite daunting, and they need so much more administrative support. So we try to develop the products in a way that they don't rely on high-tech solutions. They need to be paper-based in many cases, and so that was a big learning for us. The staff training and coaching, we realize it's not enough. You don't just go and do the training. So we have a train the trainer now model, so the local leaders can become the trainers, and really emphasizing for those people through guidelines for them how important coaching is. So after the training, to actually go and be with the staff to make sure they have what they need to do the core elements of the SAIL program. They have the resources and the training and the support, not just a one-time training, but ongoing coaching to make sure it's happening as it should. And, of course, they have told us that they would like it documented, and we found ways to work within their way of providing home support. So they have certain tasks that are documented, and they've integrated SAIL into those documented tasks so they know those core elements are being done. And also how to monitor and use the information, such as the fall report, such as the mobility tests, such as the fall risk screen, how to use all those tools to determine if you're making a difference and how to improve how you're delivering it and what you're doing. So from the fall risk scale, you can tell if you offer it before you introduce SAIL and introduce the prevention strategies. You look at the score, then you can go back and do it 6 months later and see if the score is different. Same with the mobility tests, and then you can track if falls are going down through the fall reports. We really help. They help us, and we help them, so it can become integrated and working together to make that happen. Finally, I'll just touch briefly on evaluation. It's just preliminary evaluation because we're still collecting our qualitative data and synthesizing that. But there were a few items that we have collected, and our goals were to determine the success of adapting it for cultural appropriateness and local application, determining the reach of the workshops among bands, the effectiveness of the workshops in developing knowledge, skills, and confidence to deliver the program, to determine the implementation of resources in participating communities. So after the workshop, did they implement the resources? And the spread of training to others, that train-the-trainer model. So here's a few samples of the evaluation results. So on the left, 71 bands were served. So we had 8 workshops, but people came from all these different bands, separate communities with their own home support, from 71 bands to those workshops. The populations of all the bands served total 41,808, but of those, the people 65 and over in all those 71 bands total 6,390. And then there's a male-female breakdown that's very similar. So we had a fairly good reach just from our training. Of course, there are many more bands in the province that didn't come to our initial workshops who will now have, when it's posted on the First Nations Health Authority website, access to all the resources and support from the Health Authority to deliver the training in their bands. And so of the workshops, we had 89 participants, and here's a breakdown. I won't go through it all by age and how many years in the job, and you can see that they're, average age of being 40 and 60, most of them, and at least 4 to 9 years of service. So quite an experienced group. And this next slide shows the pre-post-test quizzes. So we have a simple questionnaire about their knowledge of falls and a knowledge of the SAIL program before the training and after. And as you can see, a very significant increase in learning. And we had good response. 84% completed their pre-post tests, and a very significant increase in learning from 17 to 79%, which is excellent finding. On the right at the top, the confidence in implementing the program on a scale of 1 to 5. So after the training, did they feel they could go and use the calendar? So 4 out of 5, not too bad. Fall report, over 4. Home activity program, not as high, so that was a flag for us that we needed to do some more work. And this is over the 8 SAIL training, so it got better over time. But this is the average across all of the training programs. And using the checklist was almost 4.5. Self-rated ability to conduct the activities, understanding the scope of the problem on a scale of 1 to 3, almost 2.5. Understanding the causes, over 2.5. Identifying risk factors, quite a bit higher, 2.6, and identifying important evaluation questions, 2.45. So we're confident that the training was working overall, and as I say, it hopefully got better as we went along, and this is just the average. And finally, last evaluation results. So preliminary evaluation findings on the sale resources. So these are all the products, and this is the status of our modification of them. So the training is modified. That's done. The checklist is modified. We're still going to do a little bit more with the checklist based on the summit findings. The calendar was accepted. The fall report, no changes were needed. The home activity program, no changes were needed. Mobility assistants were only edited for clarity, and then there were the new products. The fall and fire prevention handout, the fall risk screen, the Tai Chi, and the bingo game were all new. And the modifications were made based on feedback from questionnaires, interviews, and focus groups with clients and their families, support staff and managers, and advisory committee. And I must say the most rewarding part of that was being invited into the homes of the elders to listen to their stories, and that's where so much of our learning occurred. So our next steps are to post our final products onto the First Nations Health Authority website by early 27, and there will be a component of the ones that are developed just for BC that will be only available to the staff, so not public, but there will also be a public site, and many of the products we're going to further adapt and make them available across Canada through our salefallprevention.ca website that I gave you earlier. So that concludes our talk, and I want to thank you very much for your time and welcome any of your questions.
Fantastic. Thank you so much, Vicky. So we do have a number of questions that have come in through the chat box, so I think we'll start there, and then I will give an opportunity for people who would like to ask questions over the phone to unmute their lines in just a minute or two. So a question from Holly. This is about the form reporting about falls. Is this form something that the elder is expected to fill out on their own, or do they get help from the trained staff, or do the trained staff fill it out themselves?
Thank you, Holly. That's a good question. So our main tool for the elders is that checklist, and it's a very interactive tool. And so the staff are trained in why and how to complete it, but the bands have told us that the way it works best for them, and the elders have told us what they want best, that they want that to be a tool that stays in their home. And so they are given the checklist, and they can go ahead and complete it themselves. But it's introduced by the healthcare aide, they have different names in different communities, but mostly healthcare assistant. The healthcare assistant who provides the home support goes through the tool with them and explains how it works and where they find the answers and how they can come up with their own solutions, and is taught to work with them as they're providing their normal care. We realize these are busy people. They have a lot to do to go into the homes, provide preparation of meals, provide personal care, bathing, etc. in a short period of time. They don't have a lot of time. So we ask that they talk as they provide the care about a different topic each time and gradually work through the tool. We also have learned that how important it is to involve the family, but always with the permission of the elder. Is that something they want? Sometimes they don't, and we want to respect that. So it is a mix of the elder taking the lead and doing themselves, or the staff. Now, with regard to the fall report, that's something the staff complete by interviewing the elder. So, but all those resources, the calendar, the fall reports, and the checklist, and the handout on the one-page handout on sort of awareness raising, that's all a package that goes into the homes of the elders on home support. Thank you.
Fantastic. A question from Wendy, and this is also about the fall report. How well do you believe the client is being truthful about the fall? And I guess sort of the extension of that question would be, does it matter?
Yeah, this is an issue that's it's not unique to the Aboriginal or First Nations communities that elders do not want to talk about falls. It's quite a well-documented issue. And there are people who have done a lot of work in this area. Chris Todd out of Manchester in the U.S., I think, is one of the leading researchers of this whole issue of people not wanting to talk about falls and why. And of course, there are some obvious reasons that if they are seen as fallers, they're therefore deemed as frail, and they might lose their independence. They might be moved by their family to a residential care facility, for example, a long-term care facility. In the case of First Nations people, they don't want to be seen, this is what they're telling us, as frail or vulnerable. One particular elder said to us, I don't like to use my walker because then people start asking me questions about my health. I don't want to talk about my health. And so it's a privacy issue as well. So it is a difficult issue, and the way the SAIL program is designed with the calendar and the interaction between the home care aide and the elder in that trusted relationship is the best we have found to extract that information. And much of the training of the staff is to work with the elder to bring awareness that this is not about losing your independence, it's about keeping your independence. If we can identify why you're at risk and come up with a plan to reduce that risk, the chances are you will have a longer period of independence and better health and stay in your home and stay in your community. And so that's a very big part of the training. And that reading list you were sent has some good articles that talk about that as well.
Yeah, so the reading list will be going out in the follow-up email after this webinar. So We're going to post the webinar recording on YouTube, and we'll send you that link along with a reading list and some other supplementary materials. So there's more coming. Stay tuned for that. Vicky, there are a number of questions in the chat box about the availability of both the resources and the training outside of BC. I know you spoke to it a little bit at the end about some plans to expand, but could you maybe sort of go over that again?
Sure. So the SAIL program was developed in British Columbia before the First Nations component, just for BC. But there was a lot of requests across Canada that this be made available. And so that sailfallprevention.ca website has the full SAIL program. But there's a cost recovery element. So it's not free, but it's scaled. If an individual wants to take that training, there's a very low, reasonable fee, and you can go and get the online training of the SAIL program and all the resources that go with it for the general population. If you're a large home support provider and you want to provide that training to hundreds of staff, there's a different fee. But that's available now. The First Nations components, many of the resources that I've mentioned, I've given, not many, but some of the resources are available right now, and they're freely available. And I've given websites through the presentation where that's the case. The video with the elders that promotes Tai Chi is an example. We use that video to show elders what Tai Chi is about, but also gauge their interest in wanting their own Tai Chi program. So those resources are available, but some of them, because they were just developed for BC, they're very specific to how First Nations offer home support in British Columbia only. We don't know what happens in the rest of Canada, but we do plan on working with others across Canada to further adapt and make the others available on that same sailfallprevention.ca website later next year. So not all of these resources are available today. And when I was asked to do this talk, I was clear that we are really not quite ready to do this yet because we haven't actually finished this project. But there was a lot of interest in how we were doing the project, and I think I wanted to convey that today as well.
Fantastic. And will there be a specific training component for the First Nations piece, or will that sort of just be an extension of the training that's offered for the general SAIL program?
Yeah. So the training is based on the slide package and the instructions at the bottom of each slide to the facilitator and a facilitator guide. And the First Nations version is quite different, and it really reflects that rural and remote, the rural and remote issues, and just 100 little tweaks that we've made to it based on what people were telling us in the communities. You know, how you had to pay attention to the fact that they don't have emergency telephone lines, how you had to pay attention to the fact that housing issues are a huge problem, and how houses are maintained or not maintained. And I know you've all heard horror stories on the news about some First Nations community housing, and I've seen it. It exists, and it's huge fall risk. We found out that for instance, an example would be the federal government still provides some equipment as well as local bands for grab bars, but the kind they provide don't work. They're the stick-on, clip-on type that actually are more hazardous than not having one at all, and that's what studies are showing. So the only grab bars that work are the kind that are fixed into the studs in the walls of the tub or shower. And so that's a very big part of our program, and we're actually making some headway on the change to being able to get funded grab bars that actually fit into the studs. So those are just examples of how different it is.
Okay, great. A question from Lee about if we'd be able to put back up on the screen the assessment tools. Apparently it cut out for a second at a bad moment. So would you be able to put that slide back up, Vicky?
Sure. Let me just go back. And was this the mobility or the here? So I'll go through them all. So this is the fall risk screen, and that tool is on the SAIL website in the non-First Nations version. There's quite a few free resources on the SAIL.ca website right now, and all the home activity programs and a number of these other resources. The First Nations one, we haven't finished this one yet, but that one will be on the public site on the First Nations Health Authority. These three mobility tests are readily available online, but they're also on our SAIL site. So, but they're not our tools. These are tools that have been published in studies and are available. So, tandem stance, 30-second chair stand, and timed up and go.
Great, and Lee, these will be sent out. The slides are going to be sent out afterwards, so you will have a chance to look at those in a little more detail if you want once we send you the PDF slides.
I think the biggest freely available resource is the home activity program on the SAIL. So you go to sailprevention.ca and then /client resources, and that's now, you know, the videos, the handouts, the drawings, everything's available and how to do it. So we highly recommend that one.
Thanks. A question from Cynthia. Have the resources been translated into Indigenous languages at this point?
No, and we won't be doing that. And the reason is, in British Columbia alone, there are hundreds of Indigenous languages. So that's one thing we checked with the communities, and they said no. The best thing was to put it in English because most of the elders, if not pretty well all in most communities, speak English. And there are so many sub-dialects and languages that they felt that would be far too resource-intensive.
Fair enough. A question from Natasha. Thank you for the great presentation and fantastic work that is being done. My question pertains to what happens when the report is filed with the authority. Do these ultimately get submitted as part of a national or provincial surveillance data? No, they don't, but there are a few bands that are are part of a larger study where they're using the data. There's in the Kelowna area, and I don't know a lot of the details, but there are some studies going on through the BC Injury Research and Prevention Unit on First Nations injury. So I know that they're using some of the data in that one community as part of that larger data set. But I don't have a lot of details about that. It's a good question. It would be a good thing to do. maybe Natasha, you could connect with Vicky after if you have some additional thoughts on that. Okay, one more question in the chat box from Wendy. What is available that is culturally sensitive for elders that are not frail?
Right. Well, the fall risk screen is good for any older person, or any person with mobility problems or just general health problems that put them at risk. That would be the main tool that I would recommend, is the fall risk screen.
All right. So we do have time to maybe open up the lines just for a minute or so. If someone does have a question that they'd like to ask over the telephone, feel free to unmute your line by dialing *7 now, and you can just jump on and ask your question.
It's Wendy here.
Hi, Wendy.
Hi. Just a little follow-up question for Vicky. In terms of exercise classes or physical activity options, we're struggling here in the northeast of Ontario to identify physical activity options for older adults within our Aboriginal communities that are culturally sensitive, that our elders would like to participate in. So I'm just wondering what other options might be out there. I like the Tai Chi option. I think that's a good option for us to look at, but are there any other programs that are group exercise that older adults or elders can do, and it's for elders who are not necessarily frail but maybe noticing a change in their balance?
Mm-hmm. Good question. I did a search on this a long time ago when I was working down with the Native American population, and there was a website I found, but the bottom line is that they integrated physical activity with normal activities on the land. That was a term I heard a lot, on the land. And so, making sure that there was support to get people out to do the gathering of foods, traditional foods. People who were now sort of more housebound, and making sure they had the right support to get out there and do those kind of activities where they might otherwise not be able to. Another one was to have walks that were sort of culturally relevant walks. And so they could be, one was called an eagle walk. And so the focus was on who could count the most eagles on their walk. But the point being, it was more than just a walk. It was a walk to observe something in nature that there was a traditional part of their culture is to pay attention to eagles or whatever that might be. It could be associated with gathering berries or any local activity that they would do. So those were some of the ideas. But I must say the Tai Chi, and do please watch that video, and you'll get a sense of how much the elders got out of doing Tai Chi, how it for them it fit with their spiritual beliefs. It was so motivational to watch that video. I think that will give you a sense of what they're looking for in something as by way of a group exercise. It's more than just getting your aerobic activity in. It was having a relaxation mode, almost a meditation, healing kind of quality to whatever physical activity they were doing, and the Tai Chi met that need.
Thank you.
Thank you, Vicki. That was really interesting. All right, so we are at time now. I would like to thank Dr. Vicky Scott for sharing information about this incredibly interesting and important project. Also, thank you to all of our participants today for taking the time to join us and expand your knowledge around fall prevention. As mentioned earlier, November is Fall Prevention Month, and we encourage everyone to learn more about the campaign by visiting fallpreventionmonth.ca. You can learn more about our co-hosts today by visiting Osteoporosis Canada at osteoporosis.ca and the Fall Prevention Community of Practice at fallsloop.com. Please do not close this window until you have been redirected to the Level 3 lobby screen. Once you see that screen, it's safe to close the window, and a brief evaluation survey will launch in your web browser. If you could take a few minutes to provide some feedback, it would be very much appreciated. So thank you again to everyone who was involved in this webinar, and have a wonderful day.
Thank you, Lindsay, and thank you to all the participants.